Okay, thank you for the introduction. And my name is Doug Baer. I'm the president and CEO of Brooks Rehabilitation. And this is my colleague, Debbie Reber, our VP of Clinical Services. And we're excited to talk about some of our experiences with post-acute care strategies under bundle payment environment. And again, what we'll tell you just a little bit about Brooks today to give you some context and our experiences in the CMMI bundle payment program, some of our results, and some of what we learned. So a little bit about Brooks. We are located in Northeast Florida, in the Jacksonville market is where we're based, and this just gives you a real quick snapshot. We have 6 health systems here, a number of acute care hospitals, about 1.5 million metro population, and again, we serve about 60,000 patients a year. We're a nonprofit organization, and this is our mission, vision, and values. And just what you can take away from this is we are focused on rehabilitation, doing it in multiple settings of care, but all around a rehabilitation system of care. And this gives you a little bit more of a visual about that system of care. And I think this is real important as we talk about bundle payments. And as you can see, we have up to the far left there, the top left, we have rehabilitation hospitals, skilled nursing, home care. We have outpatient therapy, our own employed physician practice. We also have assisted living and memory care, and then these community programs, which are maybe a little hard to see, but they're kind of beyond the traditional clinical settings of care and help people that are living with disabilities. But the important part about that is all of those work together, and as we treat people across that episode of care, and it was particularly helpful in the bundled programs. Just another quick visual of where Brooks is located, and you can see that Northeast Florida corner primarily. We do have some operations in Daytona and Orlando as well. And again, part of what we do at Brooks, we do research, and this just gives you some idea of the areas of focus of that research, and really in the neuro area. We also do musculoskeletal outcomes, and all of this was really part of our thought process behind getting into the bundled payment programs, because we know that's a new and emerging payment and clinical delivery methodology. So we thought it was important to be involved in that. And again, overall, to get the best outcomes for our patients, we want to invest in research. So now I want to turn it over to Debbie to talk about our participation in the program.
Yeah, so many of you might be thinking post-acute bundles, how does that work? So the program that we participated in was early on as bundles started with Medicare back in 2013. And at that time, post-acutes were allowed to be part of initiators for bundles. So we were a very early adopter. And so today we're really going to just share with you a little bit about our journey. And it truly was a journey, because many of the things that we added to our program or saw the need for came out of that realization of, wow, here's a gap, here's an opportunity, what can we learn from that, and how can we transform our services to provide better care and outcomes for our patients. So I know there's a lot on this slide, but for those of you in the group that may not be currently involved with bundles or have done them in the past, this just gives you a little indication of how bundles work. So kind of at the forefront of all of it, both bundles today as well as bundles in the very first phase of that program, it all starts with an acute care stay. So after that acute hospital stay, when they came into a post-acute service at Brooks, that is what initiated one of our bundles. So really critical was the piece that Doug shared at the beginning, how large our geographic area is and how many hospitals are in our area. So we were working closely with many acute facilities as these patients came into our inpatient rehab hospital, our skilled nursing facility, or our home care division. So that is what started the bundles with us, and they could come in at any time within 30 days of discharge from that hospital stay. For the very beginning bundles, you were allowed to select if you wanted your bundle length to be 30, 60, or 90 days. Now, as many of you know, all bundles are at a 90-day episode of care, but you'll see for most of our bundles, we selected that middle ground, the 60-day mark, and it was based on 3 years of historical data and how we performed with cost and care of those patients. Medicare takes 3% off the top of that, and then we had to beat that price. So it was all about, one, keeping the patients very well, not being readmitted or going back to ER, and at the same time, that would help to reduce that cost, and at the same time having a better outcome from them. You can see over on that right-hand side there are all the services that the patient receives, not only in a post-acute setting, but any service that patient receives is part of the bundle. So anything paid for by Medicare A or B, any physician visit, home care service, all of those services are included. At the bottom, this shows for the time period that we were in the bundle, which bundles we selected. All of these diagnostic categories are part of the episodes that are in the current advanced bundle program. So all the orthopedic types of conditions, heart failure, and then back, spine surgery. So many of those patients might include a spinal cord injury, fusions, that type of patient. All of this, again, from Medicare was around the triple aim. How do we lower cost, but at the same time have that better experience and outcome for our clients? So as we started the program, Medicare required us to submit and really very logically think of what are we going to do to have how are we going to create a program? How are we going to have better outcomes? So I will tell you, we had teams from across our system, and really an impetus for us for starting this program was how do we connect our various components of our system? How do we help patients as they transition from skilled nursing into our home care division? So we knew in order to do that, we had to have players from across the board to help us with that. And to design the program. So we came up with these 4 pillars, and they look pretty basic, but I can tell you this took a lot of time and effort and a lot of strategy into what could we do that will really have an impact and difference. So the very first thing, which is critical, and it's kind of a beating drum that you'll hear today, is what is that first post-acute care setting that they go to? So how do we know if a patient needs skilled nursing? Could patients that were in skilled go and be started in home care? We certainly have better technology to improve our services and keep the patient right in their home. So that was a big part of our program, was making sure the patient was always in the right location at the right time. We, in order to do that, created a lot of care tool decisions and worked with our clinical liaisons in our acute care hospitals as they were helping us place those patients in the best first care setting. The second key pillar that you'll see there is assessment. So as many of your health systems may be operating, our health system Of course, every division uses a different disparate EMR, and none of those systems talk to each other. And we really discovered that we weren't using any kind of core assessments across the system. So we really started standardizing, looking at the evidence, standardizing the practice that we had. And as we evolved, we created risk tools to also help predict patients that were going to be readmitted. We knew no program would be complete without really having additional care and support for our patients. So we hired care navigators and created some tools like our longitudinal care plan to help us as we transition patients across the system. The tools and technology, though, is really what, to me, stands out. We knew from the beginning, with all of our disparate EMRs, we would have to do something drastically different to connect our system and understand our patient's care path over time. And then very early on, we made a core decision that's helping us even today of ingesting all of our Medicare data and analyzing that so we could predict the cost and care paths of our patients. So this just shows you some of the risk tools that we used over on the left-hand side. The PAM, or patient engagement measure, the acuity tool that we used is LACE, some health-reported health literacy and patient-perceived risk of care to help us determine who were those patients at highest risk. And then as you see there on the right-hand side, we stored all of that information in a tool that we created called the Care Compass that helped us track each patient where they were in our care setting or outside, and then use those risk tools to identify patients at highest risk. This just kind of shows you the variation between the LACE acuity scale that you see on the left and the patient activation measure. So we knew we would have to engage with our patients in a new and different way, and we utilized the PAM tool to help us understand the variations in patient activation so we could understand how we needed to approach them and educate them differently. And then, we've talked a little bit about innovative technology and solutions through our Care Compass, but we also incorporated a lot of things after they left our care settings. So Vera was one of those, which was a virtual tele-rehab exercise program. So patients could do their exercises and receive feedback from their care teams on how they were doing once they were home. We utilized Fitbit just to look at how much people were moving or not moving. And that would sometimes trigger us to, provide a touch point to those patients in their home and just reach out to see how they're doing. And then our home care division does a lot of telemonitoring, and we added a Brooks Bell, which is like a first alarm alert system that they could press to speak with the nurse or gain additional help. So we really use technology to really interact with our patients more face-to-face, even after they left our care settings, not only with our care navigators, but with others across our team. So with that, Doug, I'm going to let you kind of share a little bit about our program results and lessons learned.
Okay, this one slide really summarizes our overall results, and they were pretty, astounding, quite honestly, to us. And this was over a 5-year period, as you can see, from 2013 through 2018, over 5,200 episodes of those diagnoses that Deb mentioned earlier. After we guaranteed Medicare 23% savings, we were able to save on average 24% compared to our historical actual costs. Very significant, obviously. But we were able to do that while increasing our patient satisfaction and really gaining very good results with functional improvement. We also had significant results with our readmission reductions in certain of the diagnoses. You can see the heart failure. We were kind of had a mixed result, I would say, on that. And Deb mentioned this, two big changes. One, the post-acute settings, and you can see less use from year 1 through year 5 of the inpatient rehab hospital, less use of skilled, more use of home care. So maybe that's a logical conclusion, but that is what happened over that 5-year period. And again, still while able to achieve high patient satisfaction and outcomes. So to wrap up what we learned, you know, our partnerships with these bundled programs, they really brought significant improvements as we look at quality, cost savings, and patient engagement. So, but particularly for certain diagnoses, and really the less medically complex diagnoses worked better. As we got into more of the congestive heart failure and even other more medically complex, it was more difficult to achieve those really great results. So, and then the third area here, the risk and gain sharing, encourage collaboration between providers. That was a big deal. We spent a lot of time with the acute care hospitals, with our own post-acute settings, and really coordinating the care. So, and again, we all should be doing that, whether we're in the bundles or not. More collaboration, more communication between settings of care, and looking at the care across the episode in a more holistic manner. And then these, big question here: who owns solving the social barriers or the social determinants of health? And sometimes I remember one story about a man after his knee replacement, climbing in his attic and having an accident and scraping it across some kind of nail or something and having to be readmitted. And, we couldn't really control that, but those are real factors that we all need to be aware of and try to manage as best we can. Deb talked about the willingness to change our belief systems and disrupt those historical care patterns. That's a key to the success of this program. And then last, but certainly not least, the use of data and understanding and being able to predict cost across the episode, utilization. That was really, really important for us, over that episode of care, and really helped us manage and be more successful. So thank you, and happy to take any questions.